Thank you. So I work for a health system, so I start all my presentations by this little disclaimer, which does say that if you see something that looks like health data, it might look like health data, but it's fake. All the data used in my presentations, aside from high-level summary statistics, is made off of demonstration data. If you're not familiar with TQIP, that is how the acronym is said. Healthcare is known for all those acronyms. And as she stated, I do have a little poster as you're coming in. I also have the QR code on the screen now, so if this presentation becomes something that you'd like to see more of in the future, I do post updates to my content, and that is also where you would find pretty much all of my previous presentations on a variety of different topics as well. So today we're just going to focus on introducing you to TQIP as a data source. And then I did write some code. It's a deliverable. It can be run with edits at your institution. TQIP is a nationally available data set, and so this is something that you could do at home. So let's start with, what is TQIP? So TQIP is a what, but it's also a who. So TQIP stands for the Trauma Quality Improvement Program, and it's carried out by the American College of Surgeons. The program actually has a lot of positive energy and detail in their website, so I highly encourage you to visit it. They are much more detailed than I can be in the time frame of the presentation today. But they do great work, and one of the things that they do is make their data available, especially to the institutions that deliver data to them. So let's take a look at what that looks like. So the data arrive by year. They follow a standard data dictionary, and you can access that via this link. If you're wondering, does TQIP have data on this? Visit the page. They got a ton of documentation out there. You can even set Copilot out on a mission, point it at the website, and you can ask it, is there data to study this? And Copilot actually does a pretty good job answering that question. The data are either purchased or available, so if your institution participates in submitting data, you get access to this data for free. If you don't participate or you're from a non-health care organization, they're available for purchase by year. Sounds great, right? Well, there's what I call a power struggle in every set of data. And so the answer is yes and no at the same time. So data can be powerful in the things that it can do, but not without a little bit of effort. And so let's understand a little bit better about what's going on in trauma research. Why is this something I'm interested in? Why is this something you're interested in? And why would you go through some of these power struggle moments to get closer to this data? So I'll start out with a poll. So raise of hands or emojis from online if there's a recording. Let's see a raise of hands. So how many in the room who are not trauma experts have you worked with healthcare data? Okay. Have you worked in healthcare? Okay. And everybody should say yes to the following question. For personal reasons or otherwise, you know, I'm sure we've all been there at one point, and this was my favorite one. You know, thinking about an ambulance that goes by, and where's that person going? What happened to them today? What happens to them next? And so, yeah, saving lives, a human favorite. I think it makes sense to all of us why that would be important, and we wouldn't call it trauma data for non-traumatic reasons. These are individuals who are maybe experiencing the worst day of their lives, and we're asking them 100 questions to go into data, but we do that for a good reason, because we get to use that data to make sure that less lives are taken when it's down to us. So, oh yes, it's a SAS programming conference, and so let's take a look at the code. So I like to be a little bit punny, like to have fun, so I call this the TQIP data equipment. And it is meant to be code that you can take home with you and run wherever you're at, as long as you have access to the TQIP data. Some of them do require some edits, but in general, once you download this code set, your code should look a little bit more like this, which are macro calls, and be able to orchestrate your programs using macro variables instead of having to write all the lines of code that I did. So let's take a closer look at the programs. So this is just a high-level look at what those are. Some of them can be used as is because they do simple things like explain where the data is. Because remember, those do come in CSV forms. You do have to put those CSVs somewhere. So the first part is just letting the program know where you've put them. It does follow a standard data dictionary, and so I've converted all of those into standardized formats and different ways to make that data look the same no matter what study you're working on. And that helps to have continuity between different study results, helps with reproducibility, and most importantly, it helps to stop explaining things to surgeons on a daily basis, because as soon as something changes, they're usually like, what has gone on? Others of them are templates. That means that you have to make an edit to them for them to work. Things like if you're pulling diagnoses, that second one there, the DX query, the edits that are needed in there is the categorization of codes. So if you're looking for specific diagnoses, you need to tell the program what diagnoses you're looking for. Different places can code in different billing codes like ICD-9 and 10. TQIP does usually use ICD-10, but they're known for changing things. And so this code is intentionally meant to be edited. And the code itself does tell you all the places that you would need to make edits. Now we'll go kind of one by one. And I'll go over just the high key takeaways of each of these programs, because again, they are available. And so you can go out and you can read the full code base, and I highly encourage you to reach out to me if you have questions when you actually sit down to go do this, if some of this isn't coming back up because this is the 100th presentation you've gone to and your notes weren't quite detailed enough. Feel free to reach out to me. So key takeaways here is, letting it know where your data is. I do these using lib name statements. If you've been programming in SAS for any amount of time, this is pretty entry level. Raise of hands, who has been programming in SAS for quite some time? Yeah, all right. So I'll go just a little bit quicker over some of the things that I think are probably common knowledge then. The next one is going to be real similar, setting up codes and formats. This is done using custom functions in PROC FCMP, and then custom formats using PROC format. Next, you have to select the population that you're hoping to study. And so this sets up the different inclusion and exclusion criteria that you're looking for in the population. It does copy reference files from the desired year, and it reshapes a lot of these fields from wide to long simply for easier reporting. SAS tends to work with long data a bit better. And so just a little bit of restructuring there. Next is some of the more technical things, things that are super common in trauma research. For example, the AIS, which measures the severity of the injury. For whatever reason, they actually provide this initially in 12 separate variables, and then the most commonly used in literature is actually by body region, but that's not part of their approach for the 12 fields they provide. In fact, right now, the AIS is actually categorized by the injury code. So each injury that a person has as they're going through a trauma event, you could break a leg and an ankle and a finger, and all those things would have different severity scores. The next is a little bit of restructuring in a way that makes for easier reporting. So one thing that is covered in the data is what I'm calling in-hospital events. These are procedures or different things that we've done to take action in the care of the patient. And again, the preference of this original data set is to be really wide. And so a lot of what this code does is convert them to a long format and then roll them up into easier reporting groups. Similarly, the shock index ratio is also really powerful in trauma research. It's an easy calculation. Maybe that's why they thought it wasn't needed in the original data set, but it's something that's almost always calculated and reported in literature. And so these are just applying some of those basic calculations, utilizing the fields that it knows will be there, and spitting out both a categorized by the common industry standard, but then also a numeric continuous variable, a little bit helpful in modeling. So the next is a frailty index. This is rather new to the industry, not because we've not worried about the frailty of individuals in the past, but just because it's become a really significant indicator of the likelihood of somebody passing away from their injuries. And so this one that I feature is for the geriatric trauma frailty index. There are others out there that I've not programmed in here yet, but this is the one that we've done in our research most recently. Next are the templates. So the first one is for diagnoses. This uses national codes and provides that diagnostic story of what happened. And some of these are pre-existing conditions, and others of them are things they're diagnosing right now as part of their injury. Similar to the diagnoses, we also have the PX, or the procedures. So these are things that have happened to patient while they're being cared for. Pretty good as I've gone through here? Nodding, good. All right, so then I'll kind of double back and go through kind of the core concepts of what's going on here. So problems you might not know you had. I'll start there, because even though the CSV is one of the best interoperability tools around, you know, so many different systems create CSVs, we use them all the time. The problems that they have are even more obvious when you're doing restructuring. And so I do have a separate presentation I've given about CSV cleaning, so if that's something you need to do to your files ahead of time, I have separate code that does that. But these, unfortunately, they don't always arrive in very cleaned up fashion. So just things to look for there. The next thing is I was talking about data transformations that I'm doing, but why was it really necessary? And for myself, it was really just to make some things like this visible. So when you're doing something by year and all of a sudden you're seeing, entire cells become missing, the ability to create something like this can be done in a variety of ways, but this is something that I produce on each study. It was something that I needed to do each time, and so it was a good place for me to develop reusable code. And then kind of just who's doing the heavy lifting here? So PROC SQL, my best friend, use SQL both pass-through and within SAS on a several billion times daily basis. I don't know the exact number, of course, but this is probably one of my favorite procs and something that I use a lot. PROC TRANSPOSE, I'm sure we're all familiar with that. Anytime I'm talking about making something wide to long, you are probably already thinking this, so I'll just confirm that for you. PROC TRANSPOSE there. And then PROC format. So PROC format can actually be quite powerful for the things that you think of first, like labeling, but also pretty helpful in executing functions and user-defined versions of those, and making sure that your data keeps a consistent feel, which in our industry, when people are in literal emergencies and they're looking at our reports as the next patient is flying through, they want to be able to glance at what we're giving them and not take too much time understanding the structure of things. So that's very important for us. And then I want you to just look at these and think to yourself, do these look new? Has anybody not seen any of these procs? No, they're pretty basic. So what I'd like to drive home here is that you can do some very powerful things with just the basic tools. So the end goal, the things that you provide and the things you can do with them are much more powerful than the solution itself. I'm just speeding it up, saving you from typing. So for me, my favorite part of my job is actually not the programming part. The programming part is what I feel most comfortable in, and it's a means to the end. But what I love about my job is the impact that I get to have on real people. So when our trauma studies come out, trauma research is one of the only industries that I'm aware of where what you find out today goes immediately into practice tomorrow. And because when it's down to the wire and they think if there's a chance that we could save that patient, we're going to do it. And so this is something I've done with this data. So this is an example of a study that would come into our area that we would explore the use of TQIP data for. So, and a little bit of medical jargon going on here, but GTFI, that's that geriatric frailty indicator. And the main question there, it says, is there a relationship between frailty and mortality? And then we're going to look a little bit closer to see, so if we say there is, what kind of things paint that picture? What's important? And if we have to ask them 100 questions, what are the top 5 that we want to make sure we ask to take the best action quickly? And so we had some secondary objectives there. This study is active as of last week. So I can't publish the results yet because we want to do that in a major journal. So I'll just be honest on that. But these are the type of inclusion criteria that I tend to see. And if you look at these numbers, we're looking at about 2.5 million rows that we're using to come up with our study outcomes. So it's not necessarily the largest data you've seen, but it's substantial. And so a reason to use TQIP as opposed to just records within our one healthcare system is really for reasons like that. We love to use this data to take things that we're seeing in our patient populations and test them against the nation. obviously, I work with a scientist who does all of the conceptual work of this. So, but what did I have to do? So I had to, look at the data. I had to understand what data was available and make sure that I could transform it into something that would help us with our outcomes. I had to pull all the supporting data, things like the demographics, the clinical qualitative, all of that stuff. And then things that I didn't necessarily know I was going to be doing before I started out on this mission. It actually wasn't super easy to merge all of the years of data because they actually changed the names of the variables, and then they kind of changed from having like an indicator for whether they received an antibiotic, and then the next year it'll be a categorical variable that needs restructuring in there. So a lot of what this code is just trying to create some consistent flow between the years of data. It's actually the biggest thing. But then how we went about that is, of course, a little bit of the massaging there. So again, I can't show you the actual results, but what I can show you is kind of just a first glance at the things that we're seeing. And just from this graphic, you can see this really large bar here. And these are people we couldn't save. It's a sad graphic if you think about it, but the fact that that frailty bar is the highest means that we're doing a really good job at identifying the patients that are at the highest risk. And so in a moment's notice, when we put these patients through a triage, we're doing a pretty great job at identifying who's that close to the wire. And so our study did look back over just the 2017 to 2023. We did consider 96 different input fields. We did a lot of model selection there, and I'm actually not our statistician. I actually do just the data part. So it's a team effort, but she, I'm sure, did something wonderful in the analysis world to help us get here. And then, how does this impact our patients? We actually didn't get this into publication yet because it's too new, but our patients started experiencing the outcomes of this study this past week. So I'm from Wisconsin. We live in an extremely rural area. We compete with horse and buggy on the road. And our ability to respond to farm injuries or car on buggy injuries or things that are probably a farmer's accident, you never really know exactly what's going to come through the door. But people do find a way to hurt themselves pretty severely, and when they do, we're there. And in case any of you are really on the business side of this, I love to show this graphic, which is the way that the impacts to clinical care affect the impact to the bottom line, and how the bottom line then continues to impact clinical care. And so we're a patient-first approach. I think most healthcare systems are. I would hope so, at least. But we'd be lying if we said we didn't really care how much it costs, or if we were, able to afford all of that, because we have to care about money. It just is how it is. So a lot of the impacts that we can do here really do increase our ability to pay for future care as well. And these are the things that I hope you learned today. I try to have just this page because sometimes I get a little bit on a tangent. And then, as I mentioned, I could not be here. I could not have done this work. The type of things that I'm talking to you about today simply would not be possible if not for Dr. Heather Rhodes, who is our trauma scientist, and the great donations that we receive to do our research every day. In this case, we did have an endowment that pays us to do our research. And then this is me. I am the operations chair for the Midwest SAS Users Group, which will be in Wisconsin this year in November. I was elected, selected, whatever verb we're using there, to this position only 3 weeks ago. And so there's a lot of things that I'm still planning. But the one thing that I'm planning is to get people in the room. And so if you have ideas, if you have things that you came to this conference today and you went, you know, I really wish I would have saw this. Or if you weren't really a dude perfect person and you think, man, I'd like to have this over lunch. I'd really like to hear your ideas. I really want the Midwest to be somewhere where people come to learn and to connect with other SAS users. It doesn't mean that the business professionals can't come. We invite everybody. But it's really a great place to meet peers and find people who are doing things just like you. And I can't tell you how wonderful it's been to really expand, like not just adding somebody on LinkedIn, but like truly when I get to a crunch and I'm like, I could spend a couple hours on Google. I definitely could. I could also just send a message to my friend Rich Ann and say, what do you think of this? And she's probably got me in like a day. And so I can focus on other things in the meantime, and I know that I can depend on my friends, my SAS friends. If you met her, she prefers sassy friends. But anyway, that's all I've got.
Any questions for Brooke? Do you have a question? I have a question because I've worked with healthcare data before. Is this something that this trauma data, does every ER have to report this to the organization?
No. So I am absolutely not familiar with the inclusion and exclusion criteria for who the participating institutions are or what the requirements for reporting are. But I do know that there are variables in there that tell me whether they're a level 1 or a level 2 trauma center or a regional one. And I'm aware that not all of the ones that are in Wisconsin are present in the data, so I know there must be some level of participation.
Okay. Any other questions, audience? Okay, then we will wrap it up. Just a reminder, if you're interested in the SAS Users Group Conference, here's the QR code. Brooke also has her Content Center QR code on the way out if you didn't catch it when she was showing it in the slides. Thank you all very much, and let's give Brooke a round of applause.